Hi there, my name is Gerard Green. I'm one of the physiotherapy lecturers here in Coventry University, and what I'm going to do for the module is go through some accessory movements that you will commonly use in clinical practice when you go out on placement. So what we will do is start with the lower limb, and the accessory movements that we're going to focus on will be the grade 3 and 4 mobilisations. So a grade 3 mobilisations is where you do a large range oscillatory movement, really going well into resistance towards the end of range. So a grade 3 movement will be a large range oscillatory movement well into range. We will also do a grade 4 movement. A grade 4 movement is a really small range oscillatory movement done towards the end of range. But I think really, in my experience and that of my colleagues in musculoskeletal physiotherapy, the movements or the mobilisations that we commonly do are probably grade 3 mobilisations. And the majority of the research has been done on grade 3 oscillatory mobilisations. People are always wondering about how long do I do these for? You know, do I do them for 30 seconds, a minute, 2 minutes? And in reality it varies. So if I see a patient who's got very low levels of pain, not really irritable, it's quite difficult to bring on their symptoms, quite difficult to flare it up, and they've got maybe a stiff joint, so I might do several minutes of mobilisations. If I've got someone who's got higher levels of pain, a little bit more irritable, easier to bring on, slower to settle down, I'll probably do them a lot less. I think a good rule of thumb for you starting out is to do a minute and then retest. So if we're doing it in an ankle joint, we might test the range of dorsiflexion or plantar flexion, do the accessory movement, and then retest that range of movement. And then we might do it for several sets more. So what we're going to start with is the foot and ankle complex. So there are multiple accessory movements you can do, but I'm going to really focus on probably some of the key ones. So, and there are several positions you can do these in, so I'll demonstrate several positions for the foot and ankle. So if we just get the model, who is my son Jake, and my son Toby's on the camera. So we've got knee at 90 degrees, ankle at plantar grade. You don't really need to kneel on the knee, it's not really necessary. So what I'm going to do is put one hand, kind of the fixating hand, on the anterior aspect, distal tib and fib. And the mobilising hand, can't really get at the back of the talus because the Achilles tendon is there. So I'm going to go on the back of the calcaneus. And this would be a PA mobilisation, really towards that talocrural ankle joint complex, but doing it through the calcaneus. My arm should be parallel, and then I'm going to mobilise like so. I'm going to do a grade 3, which is a big, large range oscillatory movement. Getting some rhythm, feeling that movement, going towards end of range. And I would do that initially for at least a minute. You should feel really nice movement when you do that on either a model or maybe someone you're self-isolating with or someone you're living with or someone that you can safely practice on. To do an AP, we would fix posteriorly distal tib and fib, hammer on the anterior aspect of the talus, forearms parallel to the ground, or plinth, and I'm going to mobilise with my left hand this time. And we feel really nice movement there. So a grade 3 would be a big oscillatory movement, well into resistance towards the end of range. Tend to feel more movement with this. We can also do an accessory movement at the mid-tarsal joint. So you'll remember really from the anatomy module that the mid-tarsal joint consists of 2 joints, laterally between the calcaneus and cuboid, and medially between the talus and navicular. So what we would do is go distal and proximal to that joint, probably fix proximally around the calcaneus and talus, and then distally around the tuberosity navicular, and then cuboid. And then I'm going to mobilise in a downward in a PA direction or upwards in an AP. I think generally I would probably do both movements together. So pragmatically, that's kind of how you tend to mobilise this joint. But if you want to really isolate it, you could do a PA or you could do an AP. But generally, they're done together. Other joint we commonly do accessory movements on is the first metacarpal phalangeal joint of the big pinky or the big toe. Commonly a sign of trauma in sports, particularly footballers who are kicking a lot. And the more elderly patient will tend to get a more of a degenerative joint. So we'll come along the shaft of that metatarsal, fix it, base of the proximal phalanx, and we can mobilise in a PA direction, going downwards, or an AP direction. So just to recap, we've done AP talocrural, PA talocrural, we come down to mid-tarsal, to an AP and PA. We come to the first metatarsal phalangeal joint. If I was going to do a grade 4, what I would do is go to the end of range, come back a tiny bit, mobilise into that end of range. But I think it's more grade 3s that you do. So we can stop the video there, please.